Hey everybody, Dr. Gerstmar from Aspire Natural Health here. I had an interesting question I wanted to share and my response to it. So, I often have students who are shadowing me, right, trying to learn, understand what's going on, how a doctor like me works, which, as most of you know, is just a little bit different from what most docs are doing. So, the question was, how do you figure out what's going on for a person? And I had to think about it a little bit. We talked back and forth, this student and I thought this just might be interesting to those of you out there. So what I wish is I had a crystal ball or a magic, tricorder from Star Trek that I could just, wave my hands over or scan someone and it would tell me exactly what's going on. Look, we don't have any of those things. We keep our fingers crossed that maybe someday we will, and technology is advancing rapidly. But for a lot of people, it's more than just testing, right? So we first start by, what the person has said. So how they filled out their forms, what do they believe is going on? Then, of course, they come down and sit in front of us. And the second piece of information you're entering into your mind when you're me or you're a doctor, right, is, what do I see? So how does the person look? What's their skin, hair, nails? What do they look like? What's their demeanor? Are they walking properly or is there something going on? Their breathing pattern, right? All these little things enter in your mind and start to give you, a glimpse of what's going on. So look, you can imagine, right? Someone who's really tired and dragging and kind of refuses to make eye contact, has a quiet voice and is super sad. You're going to think something different is going on from that person from kind of your super loud, boisterous, red-faced, person who maybe is sweating profusely in a normal temperature room, right? You're going to think, oh, maybe there's something else going on. And then of course a big part of what we do, which makes the work of natural, functional, integrative, whatever label you want to put on it, but what makes us different, unfortunately, from what a lot of MDs are doing is they simply just don't have the time. So we have, what we feel is the mandatory amount of time to spend with someone. Instead of the kind of 7 to 10 minutes of your typical visit, we spend 60 minutes at the first visit. We believe that's not a luxury, that's mandatory. So we want to sit down and hear a person's story, right? And we're trying to tease out what's going on, what are the symptoms, how did this start, what have they noticed that's helped and not helped. So again, we're inputting all of that information into it. We're trying to find out, were previous tests done, right? And what did they show? So we're always asking people, bring in your previous lab work, right? Sometimes it's incredibly helpful, sometimes it's not. So let me stop here for a second. As we're gathering all of this information in and trying to use it all to clarify a picture, there really are two different ways we're trying to arrive at what's going on. The way that we always want to work is that all the evidence, right, all the stuff that we're gathering comes together and it points to the issue. So what we call, or what I call, the direct path. In other words, like, this test, what the person's saying, all these different pieces come together and they all point to this being the issue. A lot of times, though, with our more, difficult patients, and I mean that they have more difficult things going on, the picture is not clear, right? What we have to do is what I call the Sherlock Holmes method. And that's simply ruling things out, right? So to paraphrase Sherlock Holmes, when you've eliminated all the other reasons for something, whatever remains must be the actual truth, right? So in other words, a lot of times people are coming in with, strange symptoms and we're looking through and we're trying to say, could it be this? No. Could it be that? No. And it's unfortunately sometimes this frustrating, sometimes expensive, sometimes time-consuming process of figuring out what is not going on for a person until we can home in on what is going on. So while we always try for the first process, the direct process, a lot of times, because the patients we deal with here are the patients who have more challenging issues, or the issues that have been resistant to other treatment, or the issues that have stumped other doctors, a lot of times we're using the Sherlock Holmes method, right? So we're gathering all of this information. So we've looked over the paperwork. We've sort of assessed and looked at the person who's come in. Now we're spending time hearing their story. What's going on? What have they tried? We're looking at lab work they've brought from other doctors, right? And we're looking at diagnoses that they've brought from other doctors. So this may be something like, irritable bowel syndrome, right? Now, IBS is the junk drawer diagnosis of the gastroenterology world, right? In other words, we really don't know what's going on, so we'll give you IBS. So IBS, if it's been properly diagnosed, for example, is going to tell us a few things. And that's simply put that the doctors before me have looked and they haven't found tissue destruction, tissue pathology, right? So that lets us rule out a bunch of issues that might be going on and focus on other issues. So I always tell students that not to get too caught up in the diagnosis that a person brings in. I mean, half the time, let me be honest with you, the diagnosis that someone brings in is either useless, doesn't really tell us anything, like a diagnosis of depression. Well, okay, that just means the person is depressed, but it doesn't actually tell us what's really going on for the person. Or sometimes, frankly, the diagnoses are wrong. So the patient will tell us, and I'll sit here and scratch my head and go, how in the world did you get that diagnosis? Right? Or we'll review the charts, the notes, everything, and it's just silly that the person even got that diagnosis. Having said that, we don't ignore the diagnosis because it's a shorthand to help us understand what might be going on with the person. So we take all of this information. At the first interview, we've got the paperwork, we've got the first impression of the person who hopefully is sitting in front of us, or if not, we were doing a video call and we're looking at the person. We take, extensive notes on their history of what's going on for them. We look at past lab work. We look at their diagnosis, right? We're pulling this all together to create our initial hypothesis of what's going on for the person. So in the students' follow-up question was, how exactly do you do that? And the answer, I had to think about it, was in reality, this is, a process of experience. So in your head at a non-conscious level, because I've been doing this for a while now, seeing a lot of patients and getting a lot of experience with this, we're clicking through things. Someone comes and sits down in front of you and you're thinking, what could be the issue? And then they're telling you things and you're filing away. No, it's not this. No, it's not that. Ah, yes, it might be this. Yes, it might be that. You're looking at the lab work all along, in the back of your head. You're clicking away of what might this be and what might not this be. And then we come to an initial diagnosis. And so here's the deal. I don't focus very heavily on diagnostic names. So whether it's IBS or ulcerative colitis or whatever it is, it's fine. It's a generic way that we can refer to a disease process that's going on for a person. But it's important to understand that your version of IBS or ulcerative colitis or chronic fatigue or hypothyroidism is not necessarily the same as someone else's version of that. And so it's a useful shorthand, but we don't get stuck there. The next step for me is to go from the diagnosis name to the systems of the body that we think are involved. Because, right, my process is very different. I'm not trying to correct pathology per se. So I'm not trying to necessarily correct your IBS, although I want your IBS to be corrected. What I'm looking at doing is correcting the body systems, right, so that your body can restore health and normal functioning. That's the intention behind it. So when someone comes in and says IBS, in my mind, I immediately click up to the systems and I think about, yes, of course, the digestive system. And then we're thinking, what is going on with the digestive system, right? Is it a SIBO? Is it a dysbiosis? Is there food reactions going on? Is there gut inflammation, digestive insufficiency, malabsorption, right? All of these things we're thinking upward. But then we're thinking also, could the brain and the neurology, could that system be engaged as well? And often the answer is yes. And so why? Where is that dysfunction? Could the immune system be involved? Again, inflammation, immune reactivity. Yes, of course, right? So we're thinking of these different systems of the body, and what might be going on. So at the end of that visit, I've developed a preliminary hypothesis of what's going on. Okay, IBS, but I think it sounds like there's SIBO, it sounds like there's dysbiosis, it sounds like there's a neurologic, a brain-gut connection dysfunction that's going on. In addition, I've heard that there's some degree of fatigue, so we're thinking hormonal imbalance, right? We're thinking maybe if the presentation's right, thyroid, most likely adrenals, right? Possibly other issues. We could be looking at blood sugar dysregulation. We could be looking at autoimmunity. We could be looking at other inflammatory issues, allergic, right? Possibly parasite infections, possibly toxicity issues. There's a whole bunch of things that could be playing in. And so I formulate this initial hypothesis. Then the next step is always, well, how do we prove or disprove it? And in short, we have two ways. The first is what we call a therapeutic trial. And that's simply put, a therapy aimed at what we think the dysfunction is. So if we think you have SIBO, we may do a therapeutic trial of antimicrobials, right? Things to kill that SIBO. And then sometimes that's antibiotics, and sometimes that's herbs, and sometimes that's diet, and sometimes that's a combination of these things. And if you respond really, really well to that, then we consider that the answer to that question. So the question is, in this case, do you have SIBO? Then we're undertaking a therapeutic trial to try and answer that question. If you respond by getting much, much better to that therapy, then we have basically answered that question as yes. And if you don't respond well to that therapy, then we're either saying no, SIBO is not an issue, or it's complicated, right? And more is going on. The second, aside from therapeutic trials, are actual tests, right? So do we do a stool test to look for lower intestinal, large intestinal dysbiosis, or do we do, a breath test for SIBO, or some other test for hormones or inflammation, or whatever the case may be? So we've gone from what's in front of us, what the initial diagnosis is, to the systems that are involved, and now we're testing, whether through a therapeutic trial or lab test, to try and either prove or disprove our hypothesis of what's going on. Of course, if we're doing testing, we revise our hypothesis in light of what that test tells us. So do you actually have SIBO or not? And then, of course, we are doing all treatment is essentially therapeutic trials, right? Because again, it's not just a SIBO or an IBS, right? It is your SIBO, your IBS, your thyroid problems, whatever it is. And ultimately, even though the clinical trials may tell us, right, the scientific evidence says, oh, this definitely works, the reality is what's important is how you respond. And so at the end of the day, it's always a therapeutic trial. Now, we appreciate if we have some evidence, right, some testing behind us that points us clearly in that direction. But it's that whole gestalt, right, that whole big picture of what's in front of us. What does the person think is going on? What does their history tell us? What does their family history tell us? What do previous labs tell us? What does their response to various treatments tell us, right? And through all of that, we form our hypothesis, and then we're testing that hypothesis to see if it is true. So, in a long nutshell, that is the process that I go through in order to try and figure out what's going on for a person. Folks, I hope that was helpful for you, a peek inside my mind and what I try to do on a day-to-day basis for patients. If we can help you out, please contact us at Aspire Natural Health. That's ASPIRE, Aspire Natural Health. That's all one word, aspirenaturalhealth.com. Look us up on Facebook at facebook.com/Aspire Natural Health, or give us a call, okay? We're here. We'd love to help. Until we talk next time, take care.